Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the NEEKC Foundation on improving the use of psychotropic medication among children and youth in foster care, a view from the States. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be 2 moderated question and answer sessions during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on CHCS.org tomorrow. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Kamala Allen, Vice President and Director of Child Health Quality at the Center for Healthcare Strategies.
Thank you, Travis. And thank you to everyone who has joined us today for this, what we believe is a very, very important topic. I want to start out by saying thank you to our communications team who has worked both to support today's webinar and to pull together the resource center that we launched earlier this month, Michael Canonico and Lori Martin. I'd like to thank the NEEKC Foundation and in particular our program officers, Tammy Fleming and Suzanne Bernard. I want to thank the project team, Sheila Pires, who was Senior Program Consultant, and Dr. Christopher Balanci, who was our Clinical Consultant, as well as Jessica Lipper, who was the Program Officer for this project. Finally, I would like to thank the 6 state teams who participated in this 3-year-long initiative, 4 of whom you will hear from today. I'd like to take just a second to acknowledge that we are having a major snow event here in the Northeast. And so we've tried to put a few contingencies in place should we lose power. So I'd ask that you please be patient with us. We're typically all in the room together and are able to really coordinate things by our hand signals and all of that great stuff. But today we're all in separate places. So if you have any technical difficulties, please chat those to us and we'll try to address them. We are so excited that we've had such a tremendous response to today's webinar topic. We have nearly 500 people registered for today's session, only 3 states, and those 3 states will go unnamed, that are not represented by those 500 people. So we are very glad to see the response to the topic. We have a jam-packed agenda, so we're going to move very quickly through it. You hopefully can all see the agenda slide. What we're going to do is very quickly, I will provide some context setting for the topic, and that's going to be brief because I believe most people have really been paying attention to this issue for a while. Then we'll turn to the first 2 of our state presentations, Illinois and New Jersey. We'll have a brief question and answer that will be facilitated by Pamela Tu at the Center for Healthcare Strategies. Then we'll have our last 2 presenters from Oregon and Vermont, and then we'll close with a final Q&A and some final remarks from me. What I'd like to say, and just to reiterate what Travis has mentioned, is that we really want to facilitate a dynamic question and answer period with you. So please, as you are coming up with questions, as you hear the content from the presenters, please do use that Q&A feature so that when Pamela opens up the Q&A, we have a nice set of questions that we can pull from and try to pose those as quickly as possible to our presenters. Here you have the opportunity to see the great team that we're going to be working with today on the webinar. As mentioned, there were 6 states that participated in the Quality Improvement Collaborative, 4 of whom you will hear from today. Next slide, please, Travis. So I'm jumping right in. So I want to set the context for our and for other organizations and individuals' work on this topic of psychotropic medication use among children in foster care. I'm going to move through this somewhat quickly because, again, as I said, I know most of you are well aware of the concerns. And that said, we have embedded some citations and references throughout. So if there's information that we speak to that you want to pull down on your own, you'll at least have what you need to find that. We'll end today by pointing you to a newly launched resource center on the topic, which Michael Canonico at CHCS has pulled together, which we are very, very excited about. So hopefully between those 2 things, you'll be able to find any information you need around this topic. So starting with this slide, changes in the number of children receiving psychotropic medications. The Center for Healthcare Strategies will be releasing its most recent Faces of Medicaid study on children's behavioral health service use and expense in the coming months. The first few context setting slides come from that work, and I just want to point out that these are Medicaid-only data. So for those of us who work around this population, we know that behavioral health services are paid for not only by Medicaid, but by other child-serving systems. So we just want to be clear that folks understand that these data are only looking at use and expense derived from Medicaid claims data. So the first thing we're showing here is that between 2005, when we did the initial Faces of Medicaid study, and the most recent set of analyses, which were on 2011 data, the number of children that were covered by the Medicaid program increased by about 12% to just over 32 million. Approaching 32.5 million children. That 12% increase is up from from 29 million children in 2005. 1.7 million children of those 29 million in 2005 received psychotropic medications. That's up to 2.1 million in 2011. During that same time period, Medicaid covered children receiving psychotropic medications increased by 28%. That more than doubles the rate of increase of 12% in the child Medicaid population during that time. So in other words, what we're saying is that increase in the number of children who receive psychotropic medications was not driven solely by an increase of number of children in the Medicaid program. So there's something else going on here. Finally, in the third part of this slide, we're showing you the expenditure data. So between 2005 and 2011, we saw a $1 billion, and that's billion with a B, $1 billion increase from 1.6 to 2.7 billion in expenditures for psychotropic medication. So really the point of this slide is to say that there is a compelling reason for us to be thinking about this, both in terms of clinical issues, in terms of appropriate care received by the population, and for state programs, a fiscal reason to be paying closer attention to what's happening with psychotropic medication use. Next slide, please, Travis. So here on this slide, what I wanted to quickly share was what we see in terms of the age distribution of children who are receiving psychotropic medication. The children 0 to 5 is really where we want to really draw your attention. From 2005 to 2011, the number of children increased significantly from 78,000 to 179,000 children in the 0 to 5 age bracket who were receiving psychotropic medication. So most folks probably know, if they've been involved in this issue at all, that the GAO has done a number of studies looking at what's happening with very young children as it relates to psychotropic medication use. So this is absolutely something that the feds and states are paying attention to. And we would be interested in seeing in the next set of analyses, which are likely to be 2014, what is happening with the trend? Are we seeing a decrease from 2011 to 2014, given the focus that the feds and states have had on this issue? More to come. The children, the school-age children, those 6 to 12, represent 1.1 million children, and those 13 to 18, 850,000 children. Those very young children, though underrepresented, so meaning that there are less of them in a proportional perspective who are receiving psychotropic medications in their representation in the Medicaid program, is a good thing. We really would hope to see that there would be some decrease in this. And 2 of our states are going to speak specifically about their efforts in this area. They had goals for the project they worked on with us that were specific to the very young children, and that would be Illinois and New Jersey. So we look forward to hearing from them on that. Next slide, please. So this slide is about, I think, an area that we've also been particularly concerned about, and that is children receiving psychotropic medication without any accompanying behavioral health services. So one caveat is that there may be some behavioral health diagnoses for which medication alone is appropriate, but for most, that is not the case, which is why this is an issue or an indicator that we continue to look at. So the percentage of children receiving psychotropic medication without a behavioral health service has decreased since 2005 from 49% to 42%. So the corollary to that is that we've seen a slight increase in those who are receiving them with some other behavioral health services. But still concerns persist because this is over 1 million children. As it relates to the concurrent use, so this is the right-hand side of this slide, almost 1/3 of those children who are receiving more than one of these psychotropic medications without any other behavioral health services are receiving more than one. And that is 30% for the group of children overall, but when we look at them by aid category, that rate goes up to 47% when we look specifically at children in foster care. Next slide, please, Travis. We looked at the population also by aid category. So here among children in each of the aid categories, the rate of use of psychotropic medication is from a low of 4.9% for TANF children to a high of just under 30% for children who are eligible for Medicaid by virtue of their SSI or disability status. As you can see here, children in foster care are right at a quarter of that group receiving psychotropic medications, approximating those of children with SSI and disability eligibility. The next slide, please, Travis. So here, just quickly, what I hoped to do was give a sense of the range of efforts going on legislatively, federally, and nationally. There are absolutely and thankfully too many state efforts going on for me to capture on the slide, but I just wanted to give folks access to some that might be references that you might want to go back to after the webinar. And again, also pointing you to the resource center that we'll talk about at the end of the presentation. So that's for your reference. I'm not going to go through those, but what I will do is segue, Travis. Next slide, please, to the project that we worked on with the 4 states that you're going to hear from today. Our Psychotropic Medication Quality Improvement Collaborative was funded by the NECAC Foundation. This 3-year 6-state quality improvement collaborative includes the states listed here, New York and Rhode Island, also part of that collaborative, though not presenting today. The goal of our collaborative was really to try to address the barriers that prevented states from being able to be absolutely sure that their oversight and monitoring processes for from the consent to monitoring on the back end for the use of psychotropic medication for their youth in foster care were strong, reliable, dependable, and that they had other activities that were going on around that, like educational activities, to make sure that they were able to best provide the appropriate care given the needs of the individual child. And so what I've listed here at the bottom half of this slide is the areas of focus across the 6 states. And so many of the states addressed the consent process, some going from having no uniform consent process statewide to, through the course of the project, implementing a uniform statewide consent process. There was data sharing that needed to be brought together and codified in some of the states to ensure that not only the child welfare data, but also Medicaid data and behavioral health service data was pulled together so that there was a clear picture of use, expense, and outcomes or impact of that care. And so that was absolutely something that a number of the states were focusing on. So again, I'm not going to read through all of those in the interest of time, but did want you to have a sense across the 6-state collaborative of their areas of focus. I also want to just note that we had some support from SAMHSA when we did the solicitation or the call for applications for this 3-year initiative. We had funds for 6 states. We received 26 applications from states. So that was 26 distinct applications from states. And so there was, even at that time, a very significant focus and desire on the parts of states to address this issue. And so we received some supplemental funding from SAMHSA and from Dr. Gary Blau of the Child, Family, Adolescent, and Young Adult branch to allow us to make the resources that we were developing for the 6 states with whom we were working very intensively available to the broader population of states. And so we're also very grateful and thankful for that. And I know that a number of the states reached out to us and let us know that those resources enabled them to move their agendas forward, even though they weren't able to participate in the collaborative. So I just want to acknowledge those states and Dr. Blau for that support. So what I'm going to do now is actually segue and move on to our first presentation. As I said at the outset, you're going to hear first from Illinois and New Jersey, and then Pamela Tu will jump in and facilitate the question and answer period. So with that, I'm going to ask Dr. Naylor to get us started. Mike?
Hi, sorry about that. I had to unmute my my phone. We'll start with slide number 2, I guess. Next slide. The background of the child welfare system. The Illinois is a state-administered as opposed to a county-administered system. So it's a centralized system. When we began the collaborative, we had 15,900 almost kids in care. We have since dropped down to 14,300 kids in care as of December 31st, 2017. And I'm not going to go into our system in any sort of great detail except to describe the medication consent and oversight process a little. In the late 80s and early 90s, the Department of Children and Family Services in Illinois was under a lot of criticism for providing poor services or not enough services, and ended up being sued by the ACLU and the Department of Justice. And there was a consent decree, the BH consent decree, which acted as a catalyst for a lot of developments regarding mental health services for these youngsters, including the writing of Rule 325, which guided the use of psychotropic medications for foster children. And this included putting into place a centralized consent mechanism and an oversight program. The consents were, if you look at consent as an informed consent process, DCFS in the Office of the Guardian is the consent process, and the clinical services in psychopharmacology, which is at the University of Illinois at Chicago, the informed part. We review all of the psychotropic medication consent requests that a clinician will send in. Next slide. So we set out to address 7 issues, and we quickly realized that our eyes were bigger than our time allotment and resources. And so we settled on 5. The first was coming up with an arrangement to get payment data from Medicaid. The second, assuring that all kids in foster care on psychotropic medications have the appropriate consent. Third, decreasing the rate of inappropriate medication use for preschoolers. Fourth, assuring that foster care children on second-generation antipsychotics receive the appropriate monitoring. And fifth, establishing guidance regarding maintenance pharmacotherapy and coming up with guidance as to when to stop medications. Next slide. So I'm only going to go over a couple of our goals here. The first one that we'll look at is making sure that 100% of foster children are receiving consent for their medications. And we initially started this out by comparing payment data with consent data, and we were able to obtain an interagency agreement to allow transfer of Medicaid payment to our program. The second thing that we were able to do was implement a hard edit in the state Medicaid Management Information System, which prevented pharmacies from dispensing psychotropic medications without consent. And with this, we worked obviously with DCFS, the School of Pharmacy at University of Illinois at Chicago, and the Department of Healthcare and Family Services. And financially, this was, again, one of the benefits of having a consent decree is that often it frees up some money. And so there is a budget line in DCFS to pay for this consent project. Next slide. So impact, at this point, we can say that pretty much 100% of kids in state custody are getting consent for psychotropic medications. Some kids still slip through. One of the ways of slipping through is that foster parents or whoever actually pay out of pocket to get medications, and that way they don't need to get the prior authorization from the pharmacy. No good deed goes unpunished, though, and so this is one of those times where there were some, I think, unintended consequences. The first one being that essentially now all medications for children in the foster care system require prior authorization, even those that non-foster kids on Medicaid do not require prior authorization for. And that's resulted, especially at discharge from hospitals and at times residential facilities, a delay in getting outpatient prescriptions filled. Next slide. Our second goal is to decrease the rate of inappropriate requests for psychotropic medications for preschoolers. And on this, the first step that we did was devise and distribute guidelines on the use of psychotropic medications for preschoolers. Step one on all of the disorders was obtain appropriate psychosocial interventions. We also are in the process of writing and publishing policy 325.4, which details the new process by which preschoolers are approved for psychotropic medications. So our goal is, rather than to have foster parents and caseworkers bring a child immediately to a child psychiatrist, that they would initially go to a more specialized intake program that conducts evidence-informed diagnostic assessments and refers kids for evidence-informed psychosocial interventions before they get to the point of being referred for psychotropic medications. And on this one, again, we're working with HFS, and a specific partner was the Doc Assist program. And again, this is really covered by the BH consent decree and a budget written into the state line. Next slide. So the impact on this is, while I will say we have lost access to our payment data at this point for reasons that we can talk about later. And so we don't have the hard and fast data on this, but eyeballing the data and talking to caseworkers and other people involved in the field, it's pretty clear that more kids are getting referred for psychosocial interventions before medications. We don't have the exact number yet. We are seeing that the prescribers are following recommended prescribing guidelines more than 2/3 of the time. And that's pretty significant because even at times what's not the first recommendation is still FDA approved, and they're really not stepping outside of what we would consider to be appropriate lines for prescribing medications. And then we are providing then better oversight of the design and implementation of care plans And these are particularly helpful for really high-risk kids that we are able to identify early and refer to more intensive services. Next slide. So our sustainability, there's three things that I wanted to address on this. So again, the first one is, it really is nice to have a consent decree and to have the consent process actually written into state law, because at this point, it would take a state law, it would take repealing that state law in order to get rid of the program and get rid of the funding. For some of our project, like the Under 5 program, where it looks at evaluations and psychosocial services that are being provided, they're being provided through Medicaid. And at this point, Medicaid in Illinois is moving to a managed care organization model for kids in foster care. Pretty much all other kids on Medicaid are in the MCOs, and the foster care is the last group to move to the MCOs. And so the sustainability will really depend on how effective DCFS is at negotiating a contract with the identified provider, MCO. And then last but not least, some of our sustainability is impacted by the various priorities of different directors. And unfortunately in Illinois, I think we've had 9 directors in the last 4 years, which means that some of our projects go from being high priority to low priority. And so we had to find a way to deal with that. Next slide. So what are the lessons learned? You'll hear some great lessons that are data-driven by some of the other states. And I thought I would focus more on kind of gestalt sorts of issues and working with state bureaucracies. And the first one is that things take much longer than they take. And grammatically, that doesn't make sense, but it really is the case. You have to have a great deal of persistence often to make some of these things come to fruition. Next slide. If you could hit the first play, no, go back, hit the slide, the play on this one. What I would say is that progress in a state system is more like random Brownian motion with starts and stops and movements forward and backward. Then show the second one. Then a nice laminar flow sort of a model where everything moves in one direction in a nice orderly kind of a fashion. And so we've dealt with a lot of starts and stops in our program. Next slide. And then this is one of my favorite slides here. Beware the unintended consequences of public policy on healthcare delivery. And I think that, you know, when we put the hard stop at the pharmacy, there were a couple of consequences that we learned the hard way that would be awaiting us, that, you know, we've got a pretty decent fix on now, but it's taken a little bit of while to address those. Next slide. And here is the contact information. Janet Ahern is the DCFS guardian. The assistant guardian is Lisa Robinson. On the clinical services side, I'm the director, and Catherine Francis is the associate director. So thank you.
Thank you, Mike. I want to turn now to Dr. Mary Byrne in New Jersey.
Hi, thank you, Mike. That was great. So can we begin, please, with our, there you go. Here in New Jersey, our Department of Children and Families was founded in 2006 as a cabinet-level department that is focused solely on supporting children and families. We have a children's system of care, a division on women, division on adolescents, and a lot of our work has been with the Division of Child Protection and Permanency. Our child protection and permanency, not unlike Mike's and distinct in a different, in another way, is we have centralized office, but we also have 46 local offices throughout the state. So while there is central guidance, we also have local management of families in their communities and children where they live. In each of our local offices, oh, and I should say there were, at the time that we started, 6,000, almost 7,000 children in out-of-home care. At the end of last year, we had 6,168 children in out-of-home care in New Jersey. One of the things that I think makes us unusually well-resourced is that we have child health units located within each local office. And these child health units, who are staffed by nurses from the Rutgers University nurses, who are under APN leadership and who provide healthcare case management for every child in out-of-home care. They work closely with the casework team, but they manage all kinds of things around basic general health care, including immunizations, facilitating communications between providers and casework staff, and looking out for the kids on their staff, on their caseload. We also have in New Jersey a clinical team that's composed of two, well, 1.5 child psychiatrists. I'm the chief child psychiatrist, and we have my colleague, Dr. Lydia Vender, who also serves. And we have a neuropsychologist who's full-time, who can help us looking at some of our children who have educational and developmental problems, who aren't making the progress that we look for. We also have 24-hour access to a pediatric team for consultation about youngsters who are having healthcare problems. When we think about psychotropic medication, we have, in New Jersey, we have a psychotropic policy that actually was established before the 2011 GAO report came out. We'll talk about that more in the next slide, I think. But the biological parents in New Jersey retain the right to consent to their children until parental rights have been terminated. If the parents' rights have been terminated, or if the parents are for some other reason unable to provide consent, then the local office manager of our child protection agency can provide consent. And what happens then is that a prescription that is provided by a provider in the community, I think we need to go to the next slide for this, will be offered to the caseworker. The caseworker will then bring it to the parents. If the parents are not available or do not have the rights to consent, then it will go to the local office manager. The child health unit nurses work with the casework team to develop information about the medication and the child, and to be part of that consent process. Our policy components include the need for a thorough evaluation before a psychotropic medication is prescribed, the need for a thorough evaluation, a comprehensive treatment plan that includes not only psychotropic medication, but also non-pharmacological interventions that range depending upon what it is that the youngster has been diagnosed with, and requires that there is specific written consent for any psychotropic medication, and that there be a reasonable plan of psychiatric evaluation and treatment and monitoring and follow-up. So we were concerned when we joined the PMQIC project, we were worried about challenges in improving compliance with our policy components, and then secondly, trying to figure out how we could assess the progress and well-being of individual kids who were being prescribed psychotropic medication, and third, how to identify which children on psychotropic meds in out-of-home care were at greatest risk, and how we might review and monitor them. I think so our goals as we began the PMQIC project were to improve compliance with our psychotropic medication policy components, to develop and implement a quality assurance tool to assess the progress of individual children, and to create and conduct a process for ongoing quality assurance reviews. Let's go ahead. So for the first goal, what we did was we created, and I say we, and this was totally a team project between the nursing leadership and the clinical services staff and the child psychiatrist, in which we have what were for a long time Excel spreadsheets, right? With individual children by name, by diagnosis, by psychotropic medication, who the prescriber is, and then whether or not they are being prescribed within general guidelines, within reasonable practice. And we began by developing a workshop for the nurses about psychopharmacology and psychotropic medication policy so that they would understand the concerns about psychotropic meds, because our nurses, and we have at this time, I think, about 200 of them throughout the state. Many of them come from pediatrics, some of them are behavioral health nurses, but they come from a range of backgrounds, and we wanted to be sure that they understood the issues around psychopharmacology for children and adolescents. So we conducted a workshop on psychopharmacology and psychotropic medication policy in order to be sure that we could support the effort to be sure that the policy compliance was on target. And our next goal, or our progress on that goal, is in the next slide. So we were looking at the policy components, and as we went through, what we found was that the percentage of kids who had a treatment plan in the record was able to increase significantly. And the importance of the treatment plan is that the treatment plan specified that the youngsters were also receiving non-pharmacological care. Next one, please. We also wanted to ensure that our children had current informed consent on the record for each of our kids, and that also went up over the course of the time that we were tracking it. Next. We were looking to be sure that we had a full psychiatric evaluation on the record for each of our kids in out-of-home care who are on psychotropic meds. Let's go on. Our second goal was to look at the progress of individual children who are taking psychotropic meds. And here's how that concern developed. We were beginning to develop a better sense from our psychotropic trackers. We could look at groups of kids, we could look at the number and percentage of kids who are on psychotropic meds, but we wanted to be sure that we didn't miss the individual child who was prescribed appropriately for example, a 10-year-old on ADHD meds for ADHD, or an 8-year-old with an anxiety disorder who is being prescribed an SSRI. We wanted to be sure that even those children who were on one med appropriately in dose and in choice of medication were not overlooked for their well-being. Now, the nurses had already developed a really terrific pediatric health and red flags tool that looked at their developmental progress, that was serving to cue the nurses for questions and concerns that they could follow throughout the time the kids were with us in out-of-home care. Our nurses manage everything from dental care through severe psychiatric illness. What we did was we folded into that some issues around well-being to be sure that all of the children were also doing as well as they could in terms of their academic performance, their after-school performance. They were feeling good about themselves, perhaps engaged in after-school activities, whatever it was. And this was folded into the bigger red flags tool, and then the nurses had training for that as well. And I think the training is documented in our subsequent slide. There you go. So, and that's at the end of the time that we were tracking it, but all of the nurses were eventually trained in the QA tool and use it today. I mean, it's tremendously useful. Let's go on to our next goal. So our third goal, now that we knew that we had the policy compliance and we knew that the nurses were cued and focused on the individual children in their care, so we wanted to be able to look at risk cohorts of kids who were at risk. So one cohort that we really wanted to pay attention to were youngsters who were under 6 years old on psychotropic medication. We also wanted to look at youngsters who were on more than 3 medications at the same time, because as we all know, we know a lot about medication and we know less about medication for children, but we know a lot about we know more about those two things than we do about youngsters on 2 meds at once, because of the interactions between the meds, right? And the ways in which those meds are broken down. And then when you add a third med or more, you really begin to have risk for unenvisioned, unknown, and unpredictable adverse effects. So we really wanted to keep a closer eye on any children who are on more than 3 meds, as well as the youngsters who are under 6 years old. We also at different times looked at different cohorts. But what we did was it allowed us a chance to go back and look at, after the meds were prescribed on a quarterly basis, look at the nurses' tracking dashboards to be able to get a sense of how the youngsters were doing. Let's look at the next slide. So our concern was we were looking at these cohorts, but we did not have a method for looking at it. So what we did was we developed a way of adding on to the nursing dashboard and spreadsheets columns that reflected whether or not the medication that was prescribed was appropriate to the diagnosis, appropriate to the age of the child, and even if it was outside of reasonable for the diagnosis or the age, was it in general reasonable practice based on the what we knew about this individual child. So if a youngster fell outside of those guidelines, we would pick it up and I would reach out to the local office nurse, oftentimes with our APN, who's a behavioral health nurse, and we would work with that nurse to try and figure out what was going on with the youngster. We would perhaps have a team meeting, or I might have to reach out to the prescriber. I should tell you, and I don't think that I did before, that our local office managers have the option of reaching out to me or other child psychiatrists at any time if they need additional information in the consent process. So we actually have the nurses looking at the psychotropic medication at the time that the youngster is prescribed the medication. The local office manager has the opportunity to ask us for consultation before the medication is consented to. And then finally, we have the opportunity to review the meds for all children on psychotropic meds within the state on a quarterly basis. So we feel as though with that 3-part review of psychotropic meds, we are likely to capture what's going on with our youngsters on medication in New Jersey. When we look at the questions about how sustainable is this, we've come to understand that it's so important to have dedicated staff. If we don't have dedicated staff focused on not only providing this service, but also on being able to review our practice, it's easy to lose the focus that we had during our PMQIC project. So we continue to bring ourselves back to the need to remain focused. Next slide, please. Lessons learned is that we absolutely benefited so much from being able to work with the other presenters and the ones who couldn't join us today from the other states. It gave us a much broader perspective on what other states are doing and different ways in which we can do it. And specifically, we've had a chance to really work clearly with our internal subdivisions, like the nurses and the casework staff and the CMOs, and then that joint working together has been tremendously useful. Let's go forward. And then again, the need to focus, to really continue to redirect ourselves to where we've been. I think that's it. The one other thing, we had two other goals that I did not include because we were getting too long. One was that we wanted to be able to include our tracking in our SACWIS system, and we have done that since the end of the PMQIC project. And I think that that contributes to our flexibility and our ability to do a better job in tracking kids. The other thing that we've really focused on is lifestyle issues. The importance, and the nurses really are leading the way in this, the importance of diet and exercise and sleep in overall well-being. And I think that might be it. I'm happy to take questions, but I think I'm over my time. Kamala?
Yes, thank you so much, Dr. Byrne. This is Pamela, too, from the Center for Healthcare Strategies, and I will be moderating today's question and answer sessions. As a reminder, to submit a question, please click on the Q&A icon located at the bottom of your screen. We've already had some questions come in. The first one is for Dr. Naylor in Illinois. For your children 5 and under population, can you speak a little more about how your psychosocial service array and access was increased through this process?
So the Department of Children and Family Services has regional continuity care clinics that were set up basically to provide continuity of care for kids who don't have clinicians but are discharged from the hospital. And they were somewhat underutilized, and we repurposed the clinics themselves to do these evaluations. And then there were a couple of requests for proposals that resulted in 2 additional, we still call them CCCs, and demonstration projects for projects like child and parent psychotherapy and parent-child interaction therapy, PCIT, so that there have been resources to increase the access to these assessments and psychosocial services.
Thank you so much. And the next question is for Dr. Byrne. Can you talk more about the path to consent so from your prescriber to the health unit staff or nurses to parents or some other communication pathway?
Sure. The prescribing physician or APN writes a prescription as they would normally, and the prescription is given either to the caseworker or to the resource parent if that person has accompanied the youngster to the appointment. The casework staff, if the bio parents have attended, then obviously they can consent at the time. But otherwise, the casework staff would reach out to the bio parent, as long as they still have their rights, and have them consent to the medication, and the medication is filled and goes back to the resource family. If the parents do not have the right, then what happens is the prescription is forwarded along with information from the child health unit nurse about what is known about the medication, about the youngster and the diagnosis, to the local office manager. The local office manager, who is standing in loco parentis, may just go forward and sign, or may decide that she or he would like some additional information about the medication and the rationale for using it. The best way to handle that is for them to reach out to the physician. Sometimes they seek instead additional information from our team, myself or the other child psychiatrist, about what are the risks and benefits of the medication, what do I know about whether or not it's reasonable, even though this is, for example, a younger child or an unusual combination or a medication that they have not heard of before. Sometimes what we'll do is we will just have an internal discussion. Sometimes we'll have a call with the prescriber before the local office manager makes a decision about consent. Oftentimes, it'll just be a conversation. It may just be a conversation between myself and the prescriber about trying to understand better what's going on with the youngster.
Thank you so much. Before we turn back to Dr. Naylor, one more question for you, Dr. Byrne. Would you be able to speak to any unintended consequences that you experienced as you implemented your project?
Well, you know, one of the advantages that we had is when we wrote our policy, we included a policy advisory committee that included stakeholders from pediatricians, community providers, child psychiatrists in the community, psychologists, nurses, and social workers, and other people who were involved, so that we already knew where we were going to bump into some problems in the community. I think the biggest obstacle that we face sometimes is that it can be cumbersome to write a prescription and then have to wait for that to go to the local office, for the local office to try to reach a parent, for the local office manager to decide to reach out to me, for me to get back to them, and then for us to talk to the physician. So I think there can be a delay, and I do think that that is unintended and probably necessary just because we do the best we can. I can tell you that we've had some positive effects. We've had some reductions of polypharmacy and some broader ways of thinking about it. And some, I mean, we've gotten to know one another better, I think, within the state. And I think that's, I hadn't thought of that, but I think it's been tremendously beneficial in the long run.
Thank you. We are going to jump back into the state presentations, but Dr. Naylor will just put one question to you for thoughts to discuss during the second portion of the Q&A and how you identified some of your unintended consequences of your implementation and mentioned that you have begun to address some of those. So hopefully in the next round of Q&A, you can speak to that to start us off. So I'm going to introduce Kevin George and Dr. Ajit Jetmalani from Oregon.
Thank you, Pamela. This is Ajit Jetmalani, and Kevin George and I will be alternating slides throughout this presentation. Our project in Oregon was a joint effort of the Department of Human Services, Oregon Health Authority, which oversees all of Medicaid practices, Oregon Health and Science University, and the Oregon State University Pharmacy Program, which oversees our Medicaid pharmacy practices. And we internally had determined and discussed at CHCS with our PMQIC meetings that our statutory requirements for oversight of psychotropic medicines really fell on DHS, and yet many DHS workers did not have adequate information and knowledge to make determinations about appropriate use. We also had concerns about, oh, I'm sorry, next slide, please. We also had concerns about the oversight practices that we had in place did not really reflect a redesign of our overall healthcare system, which had transitioned into CCOs, which were coordinated care organizations. And the intent was to integrate mental, dental, physical health into single entities across the state. And our oversight practices hadn't really grown with our changes in how Medicaid dollars were being spent in Oregon. And then finally, we felt that we needed more clinical and behavioral expertise in Oregon that would apply to support CCOs in their own practices around reviewing psychotropic prescribing and other health management strategies within their population. So we created goals, which are on the next slide, during our collaborative effort with the other states. And the first goal really was to get a clear set of collaborators who could be stakeholders to initiate this project. And the second goal was to improve effectiveness of our consent process, which really is not informed consent because the person who gives consent or authorization is not in the room typically. We require the supervisor to review and authorize, and Kevin will go over that a little bit more in a moment. And then we wanted to improve the safety and effectiveness of the use of medicines by utilizing best practices in Oregon. So next we'll show goal 1, which was our bringing together of stakeholders. And we brought together an advisory committee that consisted of a large number of advocates. There were 30 people at that table, but it did include psychiatrists, nurse practitioners, pediatric care providers, foster parents, youth advocates, caseworkers and social workers. I want to highlight that people with lived experience who were getting treatment and had experience in the system were participants in that process. It's very important to include all the participants that are involved. And we identified pretty quickly that when there are challenges in prescribing practices, typically the underlying issue is unaddressed trauma, which is, of course, as we all know, ubiquitous in the foster care population, and that aggression was a common driver for prescribing practices that at times appeared to be potentially inappropriate. So Kevin is going to go over our second goal.
So good afternoon. So the issues that Dr. Jetmalani just talked about as far as trauma, that was really something that is an overlay of everything we want to be doing with these children in foster care in Oregon. And so some of the trainings that we have modified with our collection or our collaboration with Portland State University, who does most of our foster parent training, and then with Oregon Health Sciences University, really is taking that to heart in most of our trainings. And we have a separate program called Trauma Informed Oregon, where they're going out and doing training with clinicians, with social workers, with community people all across the state, and trying to really improve the practice and the commonalities about how we work with kids and families in this state. The other areas that we really look for is what are some of those tools as you start saying, well, if you're not going to do medication, what are you going to do? And so collaborative problem solving was one of the areas that we identified in Oregon that we could really move into the foster care world. It's a very natural training. It's very natural for foster parents and social workers to work together on serving these children. So we piloted this project in some of our child welfare offices and found a lot of success. And one of our private agencies here in Oregon has really moved it out throughout their entire foster care population of Maple Star, Oregon as one of those areas. And we really anticipate a lot more of this over the next couple of years as we try to roll this out. Any of the medication and healthcare training, though, really has been getting it put into place. And we have a child welfare team, our health and wellness team now, who's really been able to do a lot of information out there for foster parents, for caseworkers, for supervisors, everybody involved in some of this work. And so we've done things. On the next couple slides, you'll see we've created some tip sheets. And these are as a result of the work we did with the national committee who created the Making Healthy Choices. Those booklets were really helpful, but what we really identified is that there's rarely is there going to be a young person or, quite frankly, a foster parent or even a social worker who's going to sit down and read the 30 pages. So we really try to highlight in a 2-page, front and back, what do caseworkers and advocates for children need to know, and what do youth need to know? And so that material is sent out to the youth, to the foster parents. Our caseworkers have it, and it's been really helpful in educating them both about the process, what medication is, what it is not, what some of those side effects are, and what are those questions you should ask as a young person of your doctor when you're seeing them. And then obviously we really utilize our OPAL K, which is the Oregon Pediatric Access Line for Kids. And now we have a consultation on a regular basis that we didn't have in the past from the child welfare world. It always has been a social worker by themselves, but now we have the backup support through our health and wellness team, as well as consultation on a regular basis. At the very end of our presentation here, we have a link to our website, and that's where these consent form, or these tip sheets will be found in the future here. So let me move on to actually improve the consent process. So this really was an area that it took the good old practice of a business flow. And how do you map out the business flow for staff and for foster parents? So really, the foster parent and the youth are being provided these tip sheets to better educate themselves. The clinician then is informing the child and the foster parent at the visit about why they're doing this medication, and they're providing this then to them on a form, so we're able to see that. The form then is moved through the system, and it really is one where we included a line, so the young person is signing the paper. Yes, they heard from their doctor what they're providing and why they're doing this. That form then, we took the responsibility of deciding whether to start the medication away from the foster parents. And we also heard very clearly from the caseworkers in our state, they weren't prepared to make those decisions either. And so we moved that to the supervisor. So the foster parent gets this information, they provide it to the caseworker. The caseworker then sits with their supervisor and makes that discussion about should this child move forward with this or not, and then they're providing the authorization to move forward and telling the foster parent to stop at the Walgreens and pick up the medication. So it really is the foster parent to the caseworker to their supervisor, and that's something that's very important. And in our state, we also have a statute that requires us to notify the biological parents and the child's attorney at that time. Through this improved consent process, we also got to the point where we will review every child who is on psychotropic medications on an annual basis for consistency, for what's going on, and continue to provide oversight throughout the time that they are in foster care. Ajit?
Yeah, so the next one is goal 3, which was improving the safety and effectiveness of psychotropic prescribing through best practices. We really wanted all partners in this process to understand what best practices might be. And we shared information and knowledge through a number of different avenues. One was that the Oregon Psychiatric Access Line for Kids, which is our state child psychiatry phone line for primary care providers, that program, along with the help of Oregon Council of Child Psychiatry and OHSU, developed care guides. And those care guides are infused with trauma, concerns around the impact of trauma on presenting symptoms. We created a consensus opinion regarding what would prescribing risk flags be. And we distributed those care guides and risk flags to caseworkers, supervisors, and to healthcare providers, as well as coordinated care organizations across Oregon. The next slide is just a landing page for Opal K. And just I want to point out that on the right column, you'll see care guides there, and you should feel free to look at our care guides, use them as much as you would like, download them. They're not proprietary, they're intended to be shared. So then, continuing on and improving best practices, here's a list of our prescribing flags. And polypharmacy, we decided to look at 3 or more psychotropics and define that as the level of polypharmacy that we wanted to focus on. And then you'll see the other triggers with a particular interest in working on the under 6 population, as other states have highlighted. And then those prescribing flags really are not an indication that something is being done incorrectly for that child. It's just to raise the question. We sent dashboards to providers about their prescribing practices. We sent dashboards to CCOs about their overall population of kids in foster care. And then when there's triggers, our nurse reviewer reviews all kids annually, or when there's a new psychotropic request. And if there's a trigger from one of these pharmacy flags, I am reviewing those cases personally after we obtain records. And then if I'm concerned, the case goes to Opal K for further consultation. And this is a consultation process, not a gotcha, you're doing something bad process. The next page is just a sample of what we send out. We monitor metabolic monitoring of antipsychotics to target increasing oversight with that particular psychotropic category. And then a couple more slides are some data points. We have a lot more data, but just chose to show a couple slides. One is that in 2009, when we started this work in Oregon, we had about 19.6% of our youth in foster care on psychotropics. By the end of this project, we were about 9.6%. And the following slide is actually an overview of, there is a correction to make here. The GAO report, this is all kids in Medicaid who are prescribed a new antipsychotic under 18. And you'll see that we had legislation and the GAO report, which came out in 2009, actually. And then the CHCS project was in 2011. You'll see pretty dramatic decline in first-time antipsychotic utilization. It's not clear to us about cause and effect, but we feel that this overall approach, along with a national dialogue on the diagnosis of appropriate diagnosis of bipolar disorder and other factors, may have led to a pretty steep decline in these prescribing practices of antipsychotics. Now, Kevin's going to review our sustainability and lessons learned.
Great, thank you. So when we really look at the sustainability, part of what we really looked at is this was a cultural change, or this has been a cultural change in Oregon. It's no longer just the pediatrics requirement or the child psychiatrist or the social worker. It's really all of ours together. And so, as we mentioned earlier, we've developed the health and wellness team here in child welfare, and that's really allowed us to do a lot of different things that we weren't doing in the past. And the educational materials and support for the continued children and the families and the caseworkers. The other area was really focusing on getting some shared consultation between our Oregon Health Authority, the mental health group, and child welfare. We really need to make sure we're having that consistency across. And as we already mentioned, the Opal K project, which was just piloted and then it's actually been funded. If I move to the next slide, really kind of those lessons learned from the field or for the field is truly, I think what Dr. Jetmalani spoke about earlier, was our biggest success is bringing everyone together to the table with a shared commonality. That shared commonality is the best interest of kids. And so that really has been what has been critical, both from those that are experiencing the use of medication to those that are in charge of that. So those are the areas we really want to focus on. And the other things there, I'll let you read because you can focus on the tools and collaborative problem solving, different things. But that really has been some of the focus for us. And then if I move to our last slide, this is in part trying to help out our colleagues in the Northeast who are undergoing a bunch of snow right now. And so we wanted to make sure that there was a slide that actually had a nice picture of the Oregon coast at sunset as we move forward. I want to now turn it over to Brenda on the other side of the country in Vermont.
Good afternoon, everyone. This is Brenda Gooley. I'm the Director of Operations for Family Services, and it's my pleasure to share some of our work with you this afternoon. On the next slide, you'll see I too am trying to give you a slice of life in this state, and not too easy to see the cows under the 2 feet of snow that we have right now, but we believe that spring is here. So Vermont is a smaller state, and we are a state-administered system. And when this collaborative began, we had about 1,000 children in care. I'm sure that will sound like a very small number to most of you. And today we have about 1,300. And I share that because it's significant, some of the data you'll see from Vermont. While we had a 30% increase in the number of children in care, we still have been able to positively impact this area of practice through the collaborative. So on the next slide, you'll see that we want to focus on this issue in Vermont because we followed many of the same trends that have been seen throughout the nation. We recognized that we had a much higher rate of children in DCF custody that were prescribed psychotropic medication, and we really did not have any level of data that was accurate, that was helping us to really understand what we were holding in the state of Vermont. And over time, we recognized that the antipsychotics in particular, because of the side effects that we were seeing, and I think the lack of awareness among our staff regarding those side effects and the special considerations that should be given when antipsychotics are prescribed, we decided to really focus there in our interventions. And on the next slide, you'll see that we have a quote from one of our youth in care. So this is a youth who, upon turning 18, stated, as soon as I turned 18, I took myself off the meds. And what we recognized in hindsight was that we really didn't have any sort of practice in Vermont that acknowledged that as youth were approaching adulthood, they were going to be responsible for their own consent or not, needing to get Medicaid coverage in place for themselves or choosing not to. And we really had a lot of work to do in terms of identifying those youth that were on psychotropics and make sure that we were really supporting them in making well-informed decisions themselves about that transition. On the next slide, you'll see the efforts undertaken here in Vermont through this collaborative. I mentioned before that we focused on antipsychotics in particular, and another significant piece of work that we were able to do in partnership with our Department of Mental Health and the University of Vermont Children's Psychiatry Department was to put a consultation process in place. And we, concurrent to that, put policy in place that required that whenever we had a child that was under the age of 6, or we had a child under the age of 6 that would potentially be prescribed antipsychotic medication, or a child that would be prescribed 2 or more antipsychotic medications, or a situation where dosage was exceeding the maximum recommended amount, or the child's parent objected, if any of those 4 circumstances were met, then we required our DCF workers to consult with UVM psychiatry. And in Vermont, all of the psychiatric consultation needs to occur by that DCF worker. In other words, it is the DCF worker that gives the informed consent. We do not need to go to a judge to get that authority. It's the DCF worker that is really the person that gets called upon to make that call. So putting this additional level in place really helped us to have thoughtful consideration with regard to that process. And on the next slide, you'll see exactly what that thoughtful process was. So specifically, with informed consent, what we were able to do is ensure that a UVM psychiatric fellow was providing to that DCF worker careful consideration of the diagnostic assessment, the risks and benefits, really look at the age of the child, and if that child was under 6, real careful consideration about whether that prescription was necessary, making sure that we were using only one antipsychotic medication, or if more than one, under very careful consideration, and then adding in that component of monitoring through the lab. On the next slide, you'll see just a nice overview of what we were able to accomplish. And this slide breaks down in terms of ADHD medication, antidepressant medication, and antipsychotic medication in the bars above for children 6 to 12, and in the bars below for the adolescent population. So what you'll see is this at a glance over time from 2012 to 2016, we were able to decrease the prescribing in each of those categories. The next slide takes that data a little bit further to show you we didn't actually target more than one psychotropic medication, and yet I think the very act of shining a light on this population and on prescribing practices and on the informed consent practice, we were able to see a significant decrease in prescribing of 4 or more psychotropic medications for our foster care population. The next slide shows the percentage of children in foster care that were on antipsychotic medication in the younger age group, the 6 to 12 age group, and this is from 2013 to 2016. So again, you see we were able to decrease that from about 10% of the foster care population down to 4 to 5% of that population. And the next slide shows the same for children in the 13 to 17 age group. We were again able to decrease it from about 22, 23% down to 16%. And I should clarify, our goal was not to decrease the prescribing. It was to ensure a thoughtful process and prescribing only when necessary. And I think that what we saw over time was that we did have more opportunity for treatment, not only on the path of medication. The next slide highlights some of the key tools that we used. Prior to this project, Vermont did not have policy or practice guidance that addressed prescribing practices for youth in DCF custody. And so creating that policy in and of itself was very significant. And then we had the benefit of adding consultation with UVM psychiatry that allowed for family services, DCF social workers to receive consultation if they had questions in general, and then also required consultation in those antipsychotic categories that we described earlier. The final tool that we added that was very significant for Vermont was the pharmacy tool that allowed for us to have more accurate tracking, really gave us a more rich picture of, this is the population that is being prescribed, and these are the trends that we're seeing over time. The next slide is a quote from our UVM psychiatry partner, Dr. David Ritu. And what Dr. Ritu was noting here was that when this project first launched, there was concern that prescribers might really push back and have a lot of concern about kind of the added scrutiny about their practice and what was being prescribed. But what we actually found was the feedback that we were receiving from prescribers was relief, that historically DCF workers were just giving a green light, saying whatever you feel is best. And this practice of really raising awareness of the critical thinking that needs to go into this process resulted in a true informed consent process, where there was a lot more give and take in exchanging information and making sure there really was a deep understanding of the risks and benefits of the practice. The next slide is just a brief overview of the qualitative impact that we experienced here in Vermont. So again, we have more accurate data today than we ever have that we can continue to build on. The consultation process that we have in place with UVM psychiatry is alive and well, and we continue to consult and expect to consult with them for years to come. And the tool, the pharmacy tool that we utilize, provides rich information. We've been focusing on antipsychotics primarily, but in the time to come, hope to expand that to look particularly at antidepressants and ADHD medication. In closing, with my last slide, I just want to share that Vermont has learned that with focused time and attention on these issues, we really can make a difference. This is a significant piece of work, and it's taken wonderful collaboration, and I really appreciate the collaboration of all the states involved and the work we've been able to do here in Vermont. Thank you.
Thank you so much, Brenda. This is Pamela Tu again from the Center for Healthcare Strategies. We're going to have about 7 or 8 more minutes of questions and answers here. So to start us off, I just want to jump back to Dr. Naylor. We've had a couple of questions come in regarding the unintended consequence that you spoke about, having some delays in medications at certain periods. And we're wondering if you have addressed that and have any fixes in place for that issue, possibly like temporary prescriptions.
Okay, so the unintended consequence had to do with the fact that everything takes longer than it's supposed to. And so a software program for the Department of Health Care and Family Services was identified several years ago and purchased. And then the plan was made to implement the hard stop at the pharmacy, which then required us to go from prior authorization for medications that weren't on the preferred drug list for foster kids to all medications. And that change was not communicated very effectively, unfortunately. And so for the first, I would say 2 months, there was just a lot of difficulty in terms of getting medications filled on discharge from the hospital. I'm not going to say that that problem is solved totally right now. I would say that it's probably about 85% to 90% solved, where they approve a range at the pharmacy and all possible combinations of medications to get to that dosage range. And so it's a lot of work on their part, but they're able to, I think, address not all, but most of the delays that we've had. I am on call 24/7, and there are times when after-hour consents come through that require either consent at the last minute for these medications before a kid is discharged from a hospital, or sometimes even a brand new prescription, and I will fill those. So we've got workarounds right now to address these delays. The one thing I want to say is I saw in one of the questions a question about what the delay is for these medications. Inpatients, the process typically takes about 4 hours unless there are problems with the consent. Outpatients, it typically takes about 8 hours. If a provider flags one of these requests as being high risk, the entire process would take 4 hours or less.
Thank you, Dr. Naylor. Turning to Oregon, would you be able to speak briefly about how the supervisor review of psychotropic medications works and what are the supervisor approval rates?
This is Jet Milani. The supervisor receives the faxed information from the provider, the clinical provider, and reviews that information with the caseworker and then provides approval at that moment. And if they have questions, they have access to me. They can call me, email me if they want to run a question by me, or our nurse manager who's on our team here at DHS.
Thank you. Turning to Brenda, we looked at your medication trend data up till 2016, and we had a question come in really for all the states possibly to answer that. Have you continued looking at that medication trend data, and what are you seeing?
Yes, we are continuing to look at the medication trends in Vermont. The trend lines continue to look to us like there is appropriate scrutiny occurring, and I think as many other states have mentioned as well, we are in the process ongoing of developing our trauma-informed evidence-based therapeutic treatment in concert with those prescribing practices. And so I think we'll continue to see those trend lines go down.
Great, thank you. Back to Oregon, have you looked at your medication trend data? And also, would you speak to any possible unintended consequences to your implementation process?
Well, our trending is a downward trend in all aspects of our prescribing flags. What I would say is that we have not been able to correlate changes in the experience of children in terms of quality of life measures or rates of hospitalization, emergency room visits. These are factors that I would love to further investigate because, again, it's sort of a not good or bad decision around psychotropics, but is it appropriate? And what's the overall experience of the children in care? I do want to emphasize that OPAL-K and our strategy overall focuses on psychosocial strategies and addressing trauma as a biopsychosocial view of the child's presenting symptoms, and sees psychotropics as part of that overall range of potential tools to help kids. And so I think that the end result is better practices through a more comprehensive view. And I actually don't use the word prescriber. I use the word prescribing clinician, because if you use the term prescriber, you're expecting a prescription, and really we want people to think more holistically overall about children's presenting challenges.
Thank you so much, Dr. Jetmalani. Back to you, Brenda. Have you thought about any unintended consequences from the process that you've put in place in Vermont?
Well, I think here in Vermont, I mean, I think that this is a body of work that's ripe for examination, and I think every time that we are opening the door and engaging in these collaborative relationships, we're recognizing, you know, along the way, assumptions that we made that are, you know, perhaps not accurate today, and really being able to put those pieces in place. You know, one of the areas I had highlighted briefly is just recognizing that for, you know, youth as they're aging out, how are we doing supporting them well? And, you know, our efforts have really been taking a step back from that and thinking about how we help that youth, how we ensure a youth-driven process in their own destiny that is based on the same level of education and support that we have made efforts to provide to our own DCF workers.
Great, thank you, Brenda. A question came in. I will ask it to all the states. It may be our last question of the day here, but I just want to note at this point that we've had lots of really great questions come in, and we will take the time to get those questions answered and distribute the answers to the webinar attendees. So for the last quick question, has anyone used any clinical pharmacists in their process at this point?
This is Oregon. We have a clinical pharmacist who actually worked with us the entire time that we developed this practice, and he reviews all of our kids' psychotropic prescribing practices on an annual basis, and also developed our database system.
And this is New Jersey. We have a clinical pharmacologist, clinical pharmacist on our Psychotropic Policy Advisory Committee.
Great. Well, unfortunately, that is all the time we have, but as I said, we are going to make sure these questions get answered and distributed. So I'm going to turn things back over to Kamala Allen.
Thank you, Pam, and thank you to our participants for those great questions. We look forward to responding to the rest of those and getting those out. And to our speakers, I just wanted to very quickly, in summary, cap what we hope are the things that you will take away from today's call. And I think Brenda said this, as did Ajit, is that really our goal here is not to restrict access to any service that's needed by any child or youth being served. We're not solely trying to decrease use, but really to drive toward the most appropriate use relative to the need of the child. It's critical to have a range of psychosocial interventions available, but absolutely psychotropic medications are a part of that clinical toolbox. We just wanted support efforts and provide information that can enable states to use that particular tool most appropriately. This issue related to collaboration, I think you heard that from a number of our speakers today as well, both as it relates to the ability to have a comprehensive view of the needs and the impact or outcomes of care, which depends on the ability to share data across systems. We know that we don't have use, expense, clinical outcomes, provider, all of that information in any one data source. And so we really are advocating and trying to put forward models that would give other states examples for how they might come together with their system partners to support that collaboration and to solicit stakeholder input, both from youth and family members, caseworkers, and the clinical providers. I think on a related note is this issue of workforce. All 4 of the states you heard from today embed some type of clinical expertise into their consent and review process. We are absolutely advocates of that. I think we see very clearly the impact of having that clinical review, both prospectively, as you see in Oregon, and then retrospectively, as you see, in Illinois, and then retrospectively, as you see in other states. Very, very important. And to that point, I think also on a related note is we need to have effective practices, tools, and resources that we can share with the folks who are doing this important work. We know that foster parents, birth parents, the providers, the caseworkers, and the supervisors all need appropriate, accurate information about how to use psychotropic medications appropriately, how to access appropriate psychosocial interventions, and how to communicate amongst one another to ensure that the information is getting where it needs to go. And then finally, I think as it relates to sustainability, you heard from several of the states how they have sustained aspects of this work. There have to be resources, both human and financial resources, dedicated to oversight and monitoring. And in some cases, we see states leveraging existing contracts, for example, with their managed care organizations. In other cases, there are legislative commitments to support the work. And so we just want to make sure that as we speak about resources, that we point you to the new resource center CHCS has recently launched around psychotropic medication, specifically for children in foster care. There are a number of resources that our speakers have highlighted in their presentations today, and we're hopeful that you will let us know if these are useful to you or if there are things that would be useful to you that you have not found. And finally, as we close, I think, Travis, you can put up our last slide for the CHCS website as I just speak to our desire for feedback from you about today's webinar and also input on additional topics related to psychotropic medication use. We continue to do work in this space beyond the Quality Improvement Collaborative, which has concluded. And so the best way for us to be relevant is to have input from you about what would be helpful. So in closing, I just want to again say thank you to our 4 states that participated on today's webinar, our funder at the NEEKC Foundation, and SAMHSA for our virtual learning community, and to everyone who joined us today. Thank you very much, and everyone be warm and stay safe. Thank you.